My name is Adnan Siddiqui. I'm a professor of neurosurgery at State University of New York, University at Buffalo. This is a case of primary coiling of a ruptured anterior communicating artery aneurysm. A 72-year-old female was found down at home. She was brought to the hospital stuporous and localizing in all extremities. CT scans showed significant cisternal subarachnoid hemorrhage as well as intraventricular hemorrhage. She did have prior history of hypertension and hyperlipidemia and was only on aspirin. As noted here, the CT scan shows significant amount of blood in the interhemispheric cistern as well as ventriculomegaly, which is evident particularly on the left side. CT angiogram reveals what appears to be excrescence at the anterior communicating artery, consistent with an anterior communicating artery aneurysm. As is quite common, the resolution of the CT angiogram is not optimal, and therefore we proceed with diagnostic angiography to evaluate the aneurysm further. There are risks, however, of thrombus formation, stroke, and hemorrhage from the angiogram itself. Alternatives at this point continue to remain microsurgical clipping or endovascular treatment. We elected to proceed with endovascular treatment of this aneurysm based on the anatomy that we will share with you using a 6 French access guide delivered through a 6 French access sheath in the femoral artery. We used benchmark guide for this made by Penumbra. It's delivered over a VTK Select catheter over an 035 wire. We use the SL10 microcatheter system. It's an 0165,000 system, which is perfect for delivering both 10 and 18 coils. We deliver the microcatheter over an 014 wire system. This was the Synchro 2 made by Stryker, and used Galaxy coils made by Cerenovus for coil embolization of the aneurysm. What is interesting here is that you can see a large persistent trigeminal artery supplying the distal basilar on the right side. The aneurysm fills both from the right and the left, and you can see the excrescence on angiography at the anterior communicating artery. Here you see us starting the procedure through a femoral sheath. An angiogram is performed, and now you can see the Select VTK catheter being used to catheterize the innominate. The 035 wire is being advanced into the distal internal carotid artery using the roadmap created, and now the benchmark catheter has been advanced all the way to the distal cervical, and the first intracranial runs demonstrate this aneurysm, which is being measured here, measuring about 4 millimeters inside. A rotational angiogram shows the multiple excrescences both on the dorsal and ventral surface of the aneurysm, consistent with its rupture status. In the fluoro, you can see the previously placed ventriculostomy catheter, which is in place, and now the system is being brought over an 014 wire with the SL10 catheter. Important thing to note is to really catheterize an ACA, the tip of the catheter needs to be in the clonoidal system. The wire has been used, and now the SL10 has been brought all the way up to the distal A1 at the junction of the aneurysm. The wire is used to selectively catheterize the aneurysm, and the SL10 is slowly advanced up, but note that we always leave it at the neck so that we don't have higher risk of aneurysm perforation. Here the first coil is being delivered. The catheter is acting very stable at the base of the neck, and the coil is being delivered. Now you saw the coil catheter come out of the neck of the aneurysm, and so you simply retrieve the coil back so that the catheter gets inserted back in, and we're continuing to coil this aneurysm directly from the level of the neck. You always have both AP and lateral views so you can appreciate where the catheter is as well. Now the second coil is being delivered, and we are using road mapping so we can gray out the prior coil and just see where the new coil is going. Again, you can see the coil being delivered directly from the neck of the aneurysm with the microcatheter, and after the coil is delivered, you see there is almost a complete obliteration of the filling of the aneurysm dome. The coil is now being detached, and slowly the microcatheter is getting pulled out, and you can see that The microcatheter is being withdrawn. The coil detachment system is still there, and this is the final run demonstrating complete occlusion of the aneurysm. Some learning points here are that primary coiling is an effective means of treating intracranial aneurysms. I think it's important to appreciate fetal circulation and anomalous anatomy to reduce risk and understand better. Alcock's test can sometimes better improve visualization of anterior communicating artery anatomy as well. And soft microcatheters can help with better control and finer haptics when treating an aneurysm with risky anatomy such as in a ruptured state. This patient did very well with excellent recovery and no recurrence on angiography at 1 year.